welcome back for another Sheriff of Sodium video, Improving Surgical Education and Resident Selection, How to Build Windmills and Stop Tilting at Them. This is a version of a talk that I got to give to a state chapter of the American College of Surgeons. The talk that you're going to hear is actually a little bit longer than what I gave to them because I recorded this video as a way to see how long it would take me to give the talk, and I realized that I had to cut a little bit. So you can consider this version the special edition director's cut with all the bonus scenes. I hope it makes you think. Here we go. Thank you very much for inviting me and for that generous introduction. When the chapter president asked me about doing this talk today, we were chatting on the phone, and I could tell that he was trying to see if he could place me from my time in medical school. So I had to come clean with him about the reason why he didn't remember me from when I was a medical student on the surgery clerkship. And that reason was that I actually expended quite a bit of effort to not be known. I wanted to fly below the radar when I was on my surgery rotation, so I was always the first student to volunteer to do a little extra floor work or go help out in clinic or really anything that I could do to stay out of the OR. Now, before I go any further, I need to say, I have the utmost respect for all of you for what you spend your time doing on a daily basis. To possess the temperament and the judgment and the endurance and the physical skill and the attention to detail and all the things that you have to do to be a safe and skilled surgeon, it's deserving of respect. But I kind of knew very early on that it wasn't for me. So even today, as a matter of personal and professional principle, I do my very best to stay out of the OR. But from time to time, I end up having to go to the OR to do a biopsy or something, and when I do, I'll tell you how I do it. I make a point of wearing the white bunny suit and the silly bouffant cap. A couple months ago, I was doing this, and the chief of surgery at our hospital came strolling by, and he saw me suiting up like that, and he came over. And come with me, he said, I'll show you where the locker room is, because that's where the scrub machine is, and wouldn't you like to wear scrubs? And I told him, no, thank you. I'm good. What I didn't tell him was that I actually wanted to look like a total rube in the OR, lest I be mistaken for someone who actually knew what he's doing. When you wear that bunny suit and the bouffant cap, it clearly marks you as a clueless outsider who is deserving of the OR staff's sympathy and assistance. And everyone is so nice. Anyhow, I'm telling you all this for a reason, and that reason is to convincingly demonstrate that I am not a surgeon. I'm not someone who claims any expertise at all about efficient or effective surgical training or what skills one needs to acquire to become a safe and competent surgeon. But this creates a certain challenge when I'm here to talk to you about improving surgical education. And so what I don't want to do is stand up here and pretend to be someone that I'm not and be prescriptive about what you all need to do as educators. So instead, what I'm going to give you is a talk in 3 parts. In part 1, I'm going to highlight some problems in surgical resident training. In part 2, I'm going to highlight some problems in resident selection. And then in part 3, I'm going to give you a method that you can use to fix some of these problems, and a framework that I hope you'll use when you decide on the optimal solution. And I promise this method will work. So if you bear with me, by the end of this talk, I'm going to show you how to build windmills and stop tilting at them. Let's get started. Part 1, why Johnny can't operate. Now here, I hope that my self-deprecating sense of humor has built some rapport with you all, because what I'm about to say now may step on some toes. Because when I hear surgeons talk about the current and future state of medical education, they are the most pessimistic group of physicians by far. I mean that. There are certainly doctors in internal medicine or pediatrics or other fields who worry about the rigor of medical training, or they worry that duty hour restrictions have gone too far, or that we're compromising excellence in the way that we educate students and residents today. But it is a whole lot easier to find those voices in your specialty. Here's the American College of Surgeons presidential address from 15 years ago. Why Johnny can't operate. This paper has been cited nearly 300 times. As a pediatric nephrologist, I can tell you, you're not going to find the president of the American Academy of Pediatrics or the American Society of Nephrology talking about why Johnny can't take care of kids or why Johnny can't manage dialysis. I think surgeons have somewhat unique and very sincere concerns that training in their specialty is inadequate. And there are some data that might justify that viewpoint. Here, for instance, is a paper that shows the operative performance of surgical residents in the last few months of each training year. And on the right are the PGY-5 residents getting ready to go out and practice on their own. And on 77% of operations that are defined as core procedures by the American Board of Surgery, they were practice ready, if not exceptional. And that sounds pretty good. Until you realize that 23%, or more than 1 out of 5 of these core procedures, they still needed a fair bit of help. But that's quite a rosy outlook compared to this. In this survey of fellowship program directors, the PDs said that 66% of freshly graduated general surgery residents were unable to operate for 30 unsupervised minutes of a major procedure. And they didn't stop there. According to the fellowship directors, 56% of graduating residents lacked proficiency in laparoscopy. 38% showed a lack of patient ownership. 30% could not atraumatically manipulate tissue. 28% were unfamiliar with therapeutic options. 26% couldn't recognize anatomical planes. 24% could not recognize early signs of complications. That doesn't sound real good. But I gotta wonder, how much of this is just tilting at Windmills? Because there is a long and storied history of surgeons complaining about the quality of their residents and their residents' training. Here's an old photograph of Dr. Halstead with some of his residents in 1914. It comes from an article that describes his relationship with Dr. Harvey Cushing, who's pictured there in the bow tie. Among other things, the article describes how Halstead actually relieved Cushing of his duties as a surgical resident and nearly fired him. Of course, once Dr. Cushing had left for Boston, no other resident could ever measure up to him. So I wondered, how much of this is just every generation of surgeons thinking that the one that comes after them had it easier? So I found this paper from 2014 where surgeons were asked whether general surgery resident training is adequate to transition into the attending surgery role. And these results were fascinating because there was a very clear generational divide. If you asked surgeons who were 45 years old and younger, 94% of them agreed or strongly agreed that their surgical residency training was adequate. But if you asked older surgeons, only 59% felt that current surgical training was enough. And of course, part of the impetus for this survey and analyzing these dichotomous age groups was that something very significant changed in surgical training between these two groups of surgeons, and that was duty hours restrictions. Before duty hour restrictions in 2003, the average surgical resident was working 90 to 100 hours per week. Over a 5-year residency, that works out to between 21,600 and 24,000 hours spent in the hospital. Since 2003, we've had the 80-hour work week. So even if a resident maxes out their allowable hours every single week for 5 years, they're going to finish with 19,200 hours. And when you do the math, that means there's a 10 to 20% loss of training time, which corresponds to 6 to 12 months of residency time lost compared to previous eras. And of course, it's not just that residents are in the hospital a little bit less. While they're in the hospital, they're pulled in different directions that Dr. Halstead's residents never had to worry about. These days, 38% of the average surgical resident's weekly duty hours are spent working in the EMR. So if we go back to why Johnny can't operate, Dr. Bell builds a case for sweeping reform in surgical education by making a stepwise logical argument. The first premise is that operative skill is learned, not innate. And that certainly seems right to me. I mean, nobody's born knowing just how hard you can pull on different tissues or how to dissect tissue planes or not ligate the common bile duct or safely control bleeding. Those are all skills that are hard won through experience. If we move on to the second premise of Dr. Bell's argument, it's that the current level of operative experience for residents is inadequate. And as a non-surgeon, I wanted to look at this one a little bit more closely and figure out what exactly the current level of operative experience looks like. And I'll be honest, at first I was a little surprised by what I saw. This bar chart shows the mean and median number of chief resident cases logged by each graduating chief resident from 1989 to 2011. And sure enough, there's a 10 to 20% drop in cases, corresponding with that 10 to 20% drop in hours worked that occurs right after the ACGME duty hour restrictions were implemented in 2003. But what's strange is that the number of cases actually started to drop at least 5 years before then. And what's even stranger to me is that that drop in cases was transient. After 5 years, the number of chief resident cases is essentially back up to the pre-duty hour restriction baseline. Here's another paper evaluating this phenomenon, looking now at total operative volume for graduating residents, not just chief year cases. And the number of total cases performed went up by 21% from 2005 to 2010. And there was a 5% decrease in open operations, but residents were doing 49% more laparoscopic operations and 28% more major operations than in the early days after the ACGME duty hour restrictions. And here's what's happened since then. Resident operative volume continues to increase. Except for a transient drop in chief cases back in 2020, the number of cases that graduating residents log each year continues to increase. And now, if you'll allow me to resize this graphic and align it with the y-axis of the chief resident cases from 1989 to 2011, you're going to see something really interesting. COVID-19 notwithstanding, the average chief resident today logs more cases than the average chief resident did 30 years ago. There's never been a time, at least not in the time where cases have been recorded in a standardized way, when chief residents have done more cases than they do today. So what was Dr. Bell so worried about? So let me go back to his argument, because his next key point is that learning in the operating room is poorly understood. I mean, it's easy to count how many times someone scrubbed in or stood at the table. It's a lot harder to determine what they got out of being there. And how many procedures you need to do in order to get it, it's hard to know. And it's almost certainly highly variable. I mean, it depends on a multitude of things. Did you just turn up in the OR, or did you read up on what you were going to be doing and seeing? How effective is your teacher? And maybe most important of all, how much of the operation does the surgeon let you struggle through on your own? And in that case, data like these maybe ought to concern us. This graphic shows the percentage of cases in which the resident was logged as the primary surgeon according to the VA's database. You can see there's a significant decline from 2004 to 2018, and that decline is most prominent among the PGY5 residents, in which the proportion of resident primary cases has dropped by more than half. So residents are doing more cases, but they may be doing less in those cases than they did before. As a non-surgeon, it's easy to speculate why this trend may be occurring. I mean, maybe it's fear of malpractice. Maybe it's increasing case complexity. Or maybe it's just economic. Because there's no place in the hospital where teaching is as expensive or taking a few extra minutes with a patient is as costly as it is in the OR. Here's a graphic from JAMA Surgery that shows the cost per minute of OR time, which rose to $38 in 2014. And I wouldn't be surprised if it was double that now. The OR is the financial nexus of the hospital, and administrators and surgeons alike want to keep it running as efficiently as possible. There's no extra work RVUs to collect by letting a resident figure out how to use the laparoscope. And when the revenue that you get from a procedure is fixed, the only way that you're going to increase your profit is by limiting your costs. These are problems that Dr. Halstead didn't have to worry about when he was training his residents. The final point Dr. Bell uses to justify his reforms is that surgical knowledge and skills are not necessarily transferable between operations. And this also is something that seems intuitive and has some face validity. But if you're the kind of person who likes data, I'll give you just a quick little taste. Here again are some data from a paper I showed you earlier where the surgical attendings were evaluating resident readiness for practice. 96% of residents in their final 6 months of training were practice ready or better for procedures like an appendectomy. But that dropped to 71% for partial colectomy. And if you look at less frequent core procedures, around 25% of residents weren't ready. And for non-core procedures, it's about a coin flip. So here's my point. I think that you all, as surgical educators, face a real challenge. It's hard to learn surgery. It takes a certain amount of time. But nowadays, the amount of time you have to do it, it's confined within the rigid box of a time-limited general surgery residency. And with duty hours restrictions, that box is smaller than it used to be. And at the same time, the inside of the box has grown more congested. Nowadays, you got to teach residents how to use laparoscopes and robots and do a spectrum of operations that Halstead could have only imagined. And you got to do that in an environment in which OR time is increasingly commoditized and reimbursement is getting more strained. And so far, the solution that we've gravitated to is to just make training longer. These days, around 85% of general surgery graduates go on to do fellowship. But I'll put it to you that I don't think we should just make training longer and longer. And at a certain point, we simply can't. So an appealing solution might be to shift some of what residents need to learn to medical school, so that instead of beginning their surgery residency at essentially ground zero, they arrive on July 1st with some amount of useful and translatable knowledge and skills, so that you can get them farther during the time they're with you. I'm going to leave you with that thought for just a moment as I pivot into part 2. And in part 2, we're going to talk about surgical resident selection. And I want to say just from the outset that we're not that good at this. And we weren't that good at it in the good old days either. Here's a quote from a paper in 1985. No objective or subjective selection factors predicted the level of resident performance. Here's another from 1997. We found no single predictor of success during surgical residency in applicants' admission folders. Now, if all you want to do is predict a resident's ABSITE score or ABS qualifying examination pass rate, we can do that. But if you ask faculty to assess residents as surgeons, the predictors we have, they're not that good. Here's a systematic review from a couple of years ago, and notice the lack of correlation for most of the things that we use in residency selection in terms of the faculty assessment of those residents. And we're not just bad at predicting top performers. 31% of general surgery residents require remediation. A substantial portion of this group requires remediation more than once. I don't think this percentage would be so high if program directors knew what they were getting into when they submitted their rank order list. And then there's this. 18% of categorical general surgery residents leave their program before completion. Most often, it's for another surgery program or another specialty, but this is still a big number. I mean, pediatrics, internal medicine, emergency medicine, those are all less than 5%. But in fairness, surgery program directors have a very hard job, and it's gotten significantly harder in recent years as applicants have applied to more and more and more programs. Last year, the average general surgery residency applicant applied to 73.1 programs. 73.1 programs. When applicants apply to that many programs, this is how it works out for a typical program. The average program gets 1,031 applications, reviews 484 of them in order to send 102 applicants interview invites. Then they work hard to interview 89 of those people and rank 79 of them, all just to fill 6 positions. It's a pretty daunting task. And these days, program directors have to accomplish that task with less data than they've ever had before. Here are the factors that general surgery program directors said that they used to evaluate applicants and decide who to interview. These data came from 2021, which was the last year the NRMP did a proper program director survey. And as you can see at the top of the list, we've got USMLE Step 1 and Step 2 CK scores. We've got the Dean's Letter, the MSPE, clerkship grades, class rank, AOA, awards, basic science grades, and so on. But there are important changes and trends in many of these factors that you ought to be aware of. As you all know, USMLE Step 1 performance is now reported as pass-fail. But the first-time pass rate for Step 1 has been between 92 and 98% for the past 15 years, so it doesn't really help you a whole lot when you're trying to sort through a pile of 1,000 applications. We still have Step 2 CK scores, but what you may not know is that the distribution of Step 2 CK scores has changed over time. Here I have the distribution of scores from 2010 to 2013 in blue, and from 2020 to 2023 in red. Notice just how far to the right the bell curve has shifted. The median score now is around 250. But that's not all. Notice also how the standard deviation is shrinking. Scores are being consolidated over a more narrow range, so there's less discriminatory value. Let's move on and talk about the Dean's Letter. I could talk about the Dean's Letter for a while, but in the interest of time, I'm going to focus on just one aspect, the final summative performance assessment. Only around 70% of schools provide any data or description of a student's overall performance. And interestingly, the 30% of schools that do not provide any descriptive data are not randomly distributed. When you break down schools by their U.S. News & World Report ranking, none of the top 10 schools provide any descriptive adjectives or class rank. Only around half of schools from the 11 to 50 range do, and the only schools that are bold enough to give you a numerical class rank are schools that are ranked below 50, and most of them are actually unranked in the U.S. News & World Report. What about pre-clerkship grades? Well, these days most medical schools only provide a pass-fail designation. This graphic is from the AAMC, and it shows the number of schools using pass-fail grading versus any other type. In 2021, 83% of schools used pass-fail grading for pre-clerkship courses, and as you can see, that number grows each year. In contrast, most medical schools still assign grades or honors designations in clerkships, and actually, many students achieve them. Overall, around 30% of all U.S. medical students achieve honors on their surgery clerkship. And at a quarter of U.S. medical schools, more than 40% of students get honors. The structure of the surgery clerkship has changed over time too. At many institutions, the surgery clerkship has been significantly shortened. Back when I was a medical student, I had to bob and weave and avoid the OR from a surgical clerkship that lasted 12 weeks. But now, the average number of required weeks for the surgery clerkship is 7.9. There's been a steady decrease in the number of surgical clerkships that require overnight call, whereas the number of schools that do not offer any night call whatsoever as part of the surgical clerkship has been slowly rising. And actually, surgery is the last holdout. The blue and red curves crossed over a decade ago for most specialties. Here, for sake of example, is internal medicine. You may not be that surprised to learn that many incoming surgery residents don't feel prepared for residency. 48.1% in one survey said they didn't feel prepared for residency. And interestingly, in this survey, students who had actually taken more night call felt more prepared for the rigors of surgery residency training. But what about AOA? Around 20% of matched MD applicants in general surgery were members of AOA in 2022. But AOA is an organization that's having a bit of a reckoning at the moment, based on selection practices that disproportionately exclude members of underrepresented groups. Over the past few years, a number of schools have very publicly closed their AOA chapters. These days, there's no AOA at Harvard, Yale, Mayo, UCSF, and Mount Sinai, just to name a few, and a number of other schools are debating doing the same. All right, what about the personal statement? I mean, maybe there's something in there that can help us. Maybe there is, but maybe what's in there is actually someone else's. Because here's a study that found that 4.9% of personal statements to the Brigham and Women's General Surgery residency program were plagiarized. Well, what about letters of recommendation? We can trust our colleagues, right? Well, here's an interesting study that found that 11.8% of applicants applied with at least one letter of recommendation from a faculty member that was plagiarized. And when I tell you that faculty members are plagiarizing their letters, I don't mean they're just recycling a phrase or two. The average amount of plagiarized content was around 70% of their letter. And all this talk about plagiarism, I mean, these studies are from a few years ago, which was a far more innocent time when plagiarism actually took a little bit of effort. But now, of course, applicants and faculty alike have access to ChatGPT, which can write personal statements that 63 to 74% of program directors find to be good or excellent, and that are functionally indistinguishable from authentic personal statements. All right, so what's my point? I think for some program directors, when they think about some of the trends that I've discussed, it's easy just to get mad and start tilting at windmills. You blame the schools, and you blame the applicants, and you blame the clerkship directors and the deans and whoever else for turning medical school into a big participation trophy. But I'm going to tell you something right now that's capital T true. You can get as mad as you want, and nothing's going to change. All of the trends that I've highlighted, they have different things driving them, but all of them are happening for a reason. They're the result of the incentives involved. And if you want something different to happen, you can't just get mad. You have to change the incentives. Before I move on, let me summarize what I've covered so far. I've highlighted two big problems. The first was that surgical training is confined in this rigid box of time that's smaller than it used to be, and it may be smaller still in the very near future. And into that small box, we've got more procedures to learn and more technology to master, and we have to do it in an environment when OR time is increasingly commoditized and valuable. So wouldn't it be nice if we could just shift some preliminary elements of surgery training to the medical schools so that we don't have to keep making training longer on the back end by adding more and more fellowships? At the same time, we have problems with resident selection where, in many ways, applicants are becoming less distinguishable, which makes the task that program directors face in choosing residents, which was never easy, it makes that even more difficult. These are hard problems to fix, and on first pass, it may not be immediately obvious how general surgeons can fix them. But I'm about to explain to you how the group of surgeons sitting in this auditorium right now could do something that would make medical education more rigorous and relevant and turn residency selection into a virtuous competition that could ultimately ease some of the problems inherent in surgical resident training. Because now it's finally time for part 3, where I'm going to teach you how to build windmills. This is a windmill. There are windmills all around the world, but this one happens to be in the Netherlands. A windmill is a device that allows you to convert wind power into rotational energy that you can use to solve some problem that you have. Maybe you need to grind your grain, or maybe you need to pump the water out of your fields, or maybe you need electricity. But the beauty of a windmill is that it allows you to harness a natural resource that's there all the time and then turn that power into something useful. The key inside in the windmill is the ratchet. You put in a gear like this one with a pawl that only allows the gear to turn in one direction. And that allows you to capture this natural energy that might be sometimes going in directions that you don't like and ensure that that energy moves the wheel in the way that you want it to be moved. To build a windmill, all you really need is some wind and a ratchet. So let me show you some more data. Here are applicant match rates for 2023. There's general surgery. The match rate for graduating MD students was 83%. For graduating DO students, 63%. For U.S. citizen international medical graduates, 31%. And even though I don't have it on this graphic, the match rate for non-U.S. citizen IMGs is even lower at 27%. It is a simple matter of fact that not everyone who dreams of becoming a surgeon is going to get that opportunity. And I don't need to tell you, but students who want to pursue surgery are some of the most motivated and driven students in all of medicine. And not all of them are going to get to do it. And they know that. This is your wind. Now let me show you some more data. Here are the average USMLE Step 1 and Step 2 CK scores for MD applicants who matched in surgery. Step 2 CK is in red, Step 1 is in blue. The main thing I want you to notice is that that average goes up every year. Same thing is true for research. Here's the average number of abstracts, presentations, and publications for successfully matched applicants. The number goes up every year. And it's no mystery why. I mean, these are things that you've told applicants or you've shown applicants are important to you. You want high USMLE scores? Applicants will give them to you. You want more research? Here it is. You say jump, applicants say how high. This is your ratchet. If you want something to be done differently in medical education, and if you're willing to use that difference in your residency selection process, it will be done differently. You have the wind and you have the ratchet. Say, just for example, that you want medical schools to at least offer night call as part of their surgery clerkship. And you let it be known that your program will prioritize applicants who apply having had that experience. It's not to say you won't consider other applicants, but if you come to me with this experience, you're moving to the front of the line. How long do you think it's going to take for these highly motivated students to feed back to the clerkship director and the dean that they want to take night call? Or let's say that you do something even better, and instead of just your program, you get a few programs to say the same thing. Maybe, maybe even the programs from a single state's ACS chapter. Or better yet, maybe you work through the national ACS to take up this issue. Suppose that many programs come together, and again, just for the sake of example, let's say that you believe that medical schools should report some measure of class rank in the dean's letter. And so you put that out there, and then you reward applicants whose schools do that by giving them priority into your program. How long do you think it's going to take these highly motivated and driven surgery aspirants who are looking at a 63 to 83% match rate to beat down the door of their dean's office and say, look, you got to start putting some kind of summative statement in the MSP because you're hurting us? I'm telling you, you have leverage and you can get what you want. You just have to have the courage to articulate what exactly you want and use that in your selection process, and you will make whatever number you want to make go up. Now, this is the part of the talk that I promised was coming at the beginning because I am just a humble pediatric nephrologist and medical education commentator. I can't tell you what exactly you should ask of students or what skills they ought to learn before they come to you. I don't really know what makes a good surgeon, but you all do. So before I close, I want to leave you with one more thought because you need to choose carefully what it is you ask for. If you look at residency selection from the standpoint of individual applicants, it's a zero-sum game. One person gets the chance to be a surgeon. One person doesn't. And we can change what we use to decide who wins the game. I mean, we could use USMLE scores or research or medical school prestige or who could memorize the most consecutive digits of pi. And you might get a different set of winners and losers. But at the end of the day, 83% of applicants are going to get in and 17% are not. But the thing I want you to remember is the losers don't just disappear. They're still doctors. And whether they eventually make their way back to you all in surgery or they find their way into some other field, they're still going to be taking care of patients one day. And so the nature of the competition that you set up determines what skills they're going to have when that day comes. Let me show you something. Here is the average USMLE Step 2 CK score for general surgery applicants. The red bars are the winners, the students who matched. But the blue bars, those are the losers. Those are the students who didn't match. And what I want you to see is both of these numbers go up. In fact, the average unmatched applicant in 2022 scored as well on USMLE Step 2 CK as the average matched applicant did in 2011. Same thing's true for research. Here again is that research graph. Now we got blue bars to show you how much research the unmatched applicants are doing. These days, the typical unmatched applicant has more research than the average matched applicant did in 2011. This is because you said or you showed that USMLE scores and research were important to you. So that's what applicants did. And some won and some lost. And those that lost, they now go out into the world and they've got higher USMLE scores or more research experience. How useful will those things be to those doctors or to their patients? I don't know. But the point that I want to make is this. If you zoom out and you view residency selection from the standpoint of society, it's no longer a zero-sum game. You can choose metrics that turn the competition into a silly arms race where applicants just stockpile more and more of something that doesn't really make them into any better doctors. Or you could turn into a virtuous competition where even those who don't win and don't get a residency position in general surgery, they're still left better off by having played the game. So I would urge you to identify skills and experiences that maximize the benefit for everyone. On the one hand, you could assign residency positions by lottery. Or on the other hand, you could do it by prioritizing students who took a high-level anatomy refresher class in their fourth year, or who logged 100 hours with a laparoscopic trainer during their fourth year. You'd end up with the same number of individual winners and losers, but patients might be better off if you choose some things rather than others. And I think that's about where I wanted to leave things with you all today. The drive and motivation of medical students who want to become surgeons, you should look at it as a natural force, just like the wind, that can either be chaotic and destructive or that can be harnessed to do useful work. And I hope that some of you will be inspired to start building windmills instead of just tilting at them. And folks, that's all I've got. Thanks for listening.